So the surgical timeout is a process that's been implemented across the country over the course of the last 10 to 15 years in nearly every healthcare organization. And essentially it began as an adoption of the checklists performed as a pre-flight measure in the aeronautics and airline industry. And with that in mind, eliminating human error and creating a list of essential components before, quote, takeoff really proved to be something that could be easily incorporated into a surgical procedure to eliminate any doubt or second guessing or measures that should have been done that weren't. So it's a really good fail-safe measure. The surgical timeout really began with a few essential components like the patient's name and a couple identifiers like the date of birth or medical record number, as well as the surgical site, including laterality if there's a left or a right for the particular procedure being performed, and slowly has evolved to incorporate best practice and standard of care. So every element that we can possibly control for, we like to control for, and so having the team engaged and fully involved really helps that process to eliminate any surprises. With that in mind, anybody can really voice their opinion, from the circulating nurse to the anesthesia personnel to the surgeon himself or herself. And so in doing that, it really allows everybody to take a unique perspective on what's happening and what's about to happen. And if there are any concerns or if somebody didn't think of something, even if it's not on that checklist, they're empowered to voice their concerns, and everybody can adapt to whatever's happening so that the patient has a safe outcome.
Okay, our draping is complete. Let's do our procedural timeout, please.
This is Joni Karstens, date of birth 2/23/55. She has consent for exploratory laparotomy, sigmoid colectomy, and possible colostomy.
That's correct. That's the procedure performed. I'm the surgeon, Dr. Obi.
The patient has a penicillin allergy, has received 900 milligrams of clindamycin and 80 milligrams of gentamicin at 10:25. The patient is not on a beta blocker, and the fire risk assessment would be 1.
Excellent. So the antibiotic was given within 60 minutes. Please keep an eye on the time so that if redosing is necessary, we're on top of it. Any concerns with instrumentation? No. Okay.
Patient is ground on the left thigh. Sequential stockings are on and functioning, and they have an indwelling Foley catheter draining clear urine.
Okay. There are no students or visitors in the room. Everybody knows each other. Does anybody have any other concerns to voice?
No. No. Just due to the nature of the case, we'll be in communication in regards to fluids, blood loss, any pressors needed, and any other equipment that may need.
Excellent. Let's begin.
So as our process continues to develop, we're also implementing a debriefing protocol. So this is as important as the surgical timeout before the procedure begins, because we discuss elements of the case like whether the wound classification changed or what the specimen is, and there are elements of the debriefing process that really help maintain a high quality of care as well.